Hi, everyone. Welcome to episode 5 of a comprehensive review of dermatopathology. Today, we're going to be talking about panniculitis and then switching gears and talking about disorders of collagen and elastin, everybody's favorite. So we'll begin with panniculitis, which is sort of a difficult topic, both for trainees as well as for practicing dermatopathologists. But essentially what you want to do when you see inflammation in the fat, which equals panniculitis, is you want to see if you can separate it into septal panniculitis, meaning the inflammation is predominantly in the septal fibrous tissue between the little fat sections, or lobular panniculitis, meaning that the inflammation is around the individual lobules of fat cells. And then there's also panniculitis, which is inflammation in the fat associated with large vessel vasculitis. So as an illustration of what I'm talking about, this would be septal panniculitis, where you can see these spaces between these aggregates of fat cells widened, and most of the inflammation is in the septum. It may spill over a little bit into the fat cells, but it's predominantly in the septum. Whereas this, in contrast, you can see a lot of the inflammation, well, most of the inflammation is between each individual fat lobule. You may have stuff in the septum as well, but there's a very marked involvement of the lobules of fat. You may also have a dermatitis associated with it. Remember, dermatitis means inflammation in the dermis. Panniculitis means inflammation in the fat. You may or may not, depending on the entity. So we'll start with septal panniculitis because it's the easiest one. There's generally only one category to think of if you've identified a septal panniculitis, and that's Erythema nodosum. Commonly in dermatopathology, we'll see ruptured cysts, and those can also cause a septal panniculitis. But for purposes of boards testing, they're probably not going to quiz you on a ruptured cyst causing a septal panniculitis. So erythema nodosum is kind of the prototype for this pattern of inflammation. You'll see different inflammatory cells depending on the stage of the lesion. So early on, you're going to see a lot of lymphocytes and eosinophils, and later on, you're going to start to see a lot of histiocytes and giant cells. You can have inflammation through the dermis and into the fat, or it can be later on mostly centered in the fat. Remember, the inflammation can spill over into the lobules. Nothing is perfectly clean, but it will be predominantly in the septa. Early lesions can also have neutrophils, and I'll point out what a Immature radial granuloma looks like. So here we see another section of inflammation predominantly in the fat, widening the septa. So it takes a little while to widen the septa, but initially your inflammation will also center in the septal area. Going in closer, you can see that you have inflammatory cells, a lot of lymphocytes, maybe there's some eos, but then you can start to see that there's also some histiocytes that create these pale aggregates. And it sort of spills into these lobules that are near the septum, but not too far into them. Going even closer, here are some of your giant cells, here are some of your eosinophils, and certainly there's a lot of lymphocytes in the inflammation, showing this has got primary inflammation. Here you see a little bit of these foamy cells. Those are just histiocytes that are eating up kind of damaged fat cells that are being incidentally damaged here at the border of the septum and the rest of the subcutaneous tissue. This is a Immature radial granuloma where you see, histiocytes and then a hole in the middle. And you'll see these granulomas form with time in the septum. Here's another example of erythema nodosum, and you can appreciate the very widened septa. Here, you do have some involvement of the lobules. You can see from even low power that your fat cells vary in size, but generally, that there's a little bit of fat necrosis, and I think this case had a little bit of Lipodermatosclerosis change, which you'll see a little bit of fat necrosis with that. We're talking about lower legs here with erythema nodosum, so you may have additional findings associated with chronic stasis, etc. So in this particular biopsy, again, looking in closely at the septa, you see a lot of inflammatory cells and fibrosis. Here are your giant cells. And then here you can see a little bit of this lipomembranous change we'll point out later, which is the Lipodermatosclerosis that we also see here. And that can explain a lot of this fat necrosis You see this fat of varying sizes. That means that the fat has been damaged and is getting cleaned up. But also the widened septa and the inflammation that came with, first lymphocytes and eos and then giant cells indicates that there's also this erythema nodosum process going on. Okay. So switching gears, we're going to talk about lobular panniculitis, and this is a much more difficult topic because the differential is more broad. And so because this review is kind of an introduction to dermpath and how to approach slides, this is not an exhaustive list by any means, but there are some features that will help you distinguish one entity from another, and there are certainly ones that are differentials of each other. So we'll try to point those things out. So lobular panniculitis, as I mentioned, is inflammation around the fat, individual fat lobules, sorry. And so erythema induratum will be, possibly granulomatous because we're dealing with an infectious process here. Lupus panniculitis and subcutaneous Panniculitis-like T cell lymphoma will be a very lymphocyte-heavy inflammation. Traumatic fat necrosis, as we pointed out, is going to have little primary inflammation, right? Because it's not an inflammatory process. You'll mostly have those foamy histiocytes there cleaning everything up. Pancreatic panniculitis or alpha-1 antitrypsin, any of those are going to be neutrophil heavy. And then Lipodermatosclerosis, as we saw, is going to have this sort of lipomembranous change of the fat and a little bit of cleanup inflammation. Early on, you can see, more acute inflammation, and it can be difficult to distinguish that from erythema nodosum. But later on, when we are talking about the champagne bottle changes, that's when it's very sclerotic and not so inflammatory. And then, of course, there's subcutaneous fat necrosis of the newborn that has that sort of pathognomonic crystal change. So we'll begin by talking about erythema induratum and nodular vasculitis. They're probably one and the same condition. In this one, they did not see a very marked vascular involvement when they named erythema induratum. And then nodular vasculitis, which has similar findings, but with a vascular component, when they started doing PCR, they realized, they could find organism there too. So they're probably a spectrum of presentation of, a tuberculosis infection. So you will see septolobular panniculitis. So again, it's lobular, but it also involves the septum. And you have varying degrees of granulomatous inflammation, and you may have vasculitis. And you can have vasculitis of the veins and the arteries of all different sizes. So here you can see from this biopsy that there's very little going on in the dermis, and most of your inflammation is in the fat and below. And you have a lot of inflammation between each of the individual fat lobules. And when you go in closely, you're going to see neutrophils with a lot of dust, and you're going to see histiocytes. These pale cells are the histiocytes forming granulomas. See, here's some multinucleate giant cells, here's some multinucleate giant cells. And as we're going to see in the infection chapter, anytime you see suppuration, which means neutrophils, with granulomatous inflammation, which is aggregates of histiocytes, you really need to think about infection. So individual lobules of fat with inflammation surrounding suppurative and granulomatous. Obviously, it'll be very lymphocytic also. And that was an example of erythema induratum, which clinically we know tends to happen in the back of the lower legs as opposed to erythema nodosum, which tends to happen in the front of the lower legs. Here's an example of nodular vasculitis. We can see again this prominent lobular panniculitis, and then we see fairly prominent vascular involvement. So up close, again, you have this granulomatous infiltrate, you have lymphocytes, maybe not so many neutrophils in this particular case, but then when you go in close, you can see obvious vascular involvement. Here's a little muscle-walled artery and some mixed inflammation surrounding it. So lupus panniculitis. Lupus panniculitis, like I mentioned earlier in the introduction, is going to be more lymphocytic. As we saw in lupus, it was in our lymphocytic vasculitis, quote unquote, section where we had a superficial and deep dermal lymphocytic infiltrate. Well, if that lymphocytic infiltrate extends into the fat in a lobular pattern, then you have lupus panniculitis. Just like the dermatitis, you may see lymphocytic dust, the karyarexis, and you might look in the dermis for the interface and the dermal changes that give you a clue that you're dealing with lupus. This particular inflammatory pattern creates a lipomembranous change of the adipocytes, which we also mentioned can happen with Lipodermatosclerosis. And that's where the cell dies in a way that creates this kind of hazy, wavy effect on the fat cells. So here's an example of lupus panniculitis, and you can see a prominent dermatitis with the superficial and deep lymphocytic infiltrate. It looks lymphocytic from here because I see black dots. And then you can see in the fat a lobular panniculitis with more black dots. Going in closer to the fat, what you can see is a predominantly lymphocytic infiltrate. You don't see as many of those granulomas forming as we did with Erythema Induratum. And you can see that the fat cells are being damaged. There's this kind of hazy redness around them, and you might start to see a little bit of this kind of wavy lipomembranous change. A favorite board's question is, which two entities can you see lipomembranous change with? And the answers are Lipodermatosclerosis and lupus panniculitis. Here is another section of that biopsy showing lipomembranous, death of the adipocytes. You see adipocytes of varying sizes indicating they're being damaged, a lymphocytic infiltrate, and look how much nuclear dust there is, but there's no neutrophils in sight, right? This is not leukocytoclasis type karyarexis. This is lymphocytic dust. So lymphocytic karyarexis, which I tend to see very often with collagen vascular diseases. Here's a look at the epidermis, and you can see this vacuolar change, the white spaces at the DEJ. And if you look around closely, you might see a necrotic keratinocyte here or there, indicating there's a subtle interface. And then you have a perivascular lymphocytic infiltrate. You probably have periadnexal lymphocytic inflammation also. Here's a little pigment dropout indicating the damage at the DEJ. So in contrast, the main differential will be a panniculitis-like T-cell lymphoma. And there's even a question clinically as to whether there is a progression potentially from lupus panniculitis to a panniculitis-like T-cell lymphoma. But either way, you have another lymphocyte-heavy infiltrate in a lobular pattern in the fat. And in this case, you'll have atypical lymphocytes. So these should be a little bit larger, a little bit darker, a little pleomorphic, meaning they look a little bit different from one another, that rim the adipocytes. You can also have fat necrosis and dust, so it can be hard to distinguish from lupus. But here you can see that you do not have that prominent dermatitis like we did with the lupus panniculitis, and most of the inflammation is centered in the fat, very prominently among the lobules. And even from low power, you can see your fat cells vary in size. So there's damage to the fat. Going in, you can see more closely, we have a very lymphocyte heavy infiltrate. Certainly there's a lot of histiocytes mixed in. Lymphocytes can bring histiocytes, and it's been reported in panniculitis-like T-cell lymphoma that you can have full-on granulomas that form. But here up close, look at the rimming of these adipocytes and look at these lymphocytes. This might be a normal lymphocyte. Look at that lymphocyte. Look at that lymphocyte. It's very dark. It's irregular in size and shape. They're large. They're pleomorphic. Hyperchromatic is when you have extra chromatin. That's what it means when they're very, very black and dark. So this is what panniculitis-like T-cell lymphoma looks like. And here in contrast, you can see these are normal sized lymphocytes. They're causing damage to the fat, and they're surrounding the adipocytes, but they don't necessarily rim them the way these do. Okay, we alluded to traumatic fat necrosis earlier several times. And so here, again, driving the point home, your adipocytes vary in size because they're being damaged. And then there's some fibrosis if it's been going on a long time. And you will see inflammatory cells, but it'll mostly be these small collections of the foamy cells, which are the histiocytes, eating up the damaged fat cells. It's more of a cleanup job inflammation rather than primary inflammation where you might see lymphocytes or true granulomas or neutrophils or eosinophils, etc. So here from low power, it looks like any other lobular panniculitis. You see a lot of inflammation between the fat cells. You see the fat cells of varying sizes, but it's really hard until you go up close to see that there really isn't much primary inflammation going on. Mostly what you see is these fat cells of varying sizes, and all of these little dots really are nuclei of these foamy cells, these foamy histiocytes just cleaning up the fat. In contrast, this is a paraphenoma, and you can see these look like fat cells of varying sizes, but they don't actually have nuclei. They're not actually adipocytes. And this is nodulocystic fat necrosis, where sometimes you can get fat necrosis from trauma and you'll get this little fibrous band around it and it'll choke it off. And people will note after they've traumatized an area, they have this little marble that moves around. And that's what nodulocystic fat necrosis is. Here's another example of a recent case of fat necrosis. This is a very exuberant case of fat necrosis, and you see granulomas forming, and you even have some hemosiderin, which is from blood, right? So there was blood here, and you have this yellow material, which you can see with extensive fat necrosis. Here you even see what looks like lipomembranous change, as this fat is just getting eaten up by giant cells and cleaned up. This may have not been from outside trauma. This may have been from an injection or something that caused fat necrosis. All right, so pancreatic panniculitis, alpha-1 antitrypsin-induced panniculitis, these things can cause a panniculitis that's prominent with neutrophils. It's lobular. What you're going to see is with pancreatic panniculitis, this liquefaction due to the enzymatic fat necrosis. So you release all those enzymes when you have panniculitis, and what they do is they basically melt down the fat cells, and then you accumulate these calcium deposits, and it's actually quite beautiful and colorful, but you're like melting away your fat. So here is a photograph. Here are your neutrophils, and here are your fat cells that are not only dying, but they're kind of melting away. And this is all the liquidy fat melted away. It's a little bit blue because it calcifies as it's doing so. So saponification is a word that's been used for this. Liquefaction is just this melting away and this kind of blue aggregated material that's happening among your fat. Here's a lower power view of that. So the neutrophils and the melting of your fat. Okay. Lipodermatosclerosis we talked about. Late, you're going to see fibrosis and sclerosis of the septa. So it's important to remember that there's actually stages in lipodermatosclerosis, and I've had a few cases where early on you should know that it really is tender and nodular and can be very difficult to distinguish both clinically and histopathologically from erythema nodosum. But over time, you're going to have this fibrosis and sclerosis of the septa and the lipomembranous change that we talked about earlier, and you may or may not have fat necrosis, and you should see evidence of stasis changes in the dermis. So here is a picture of lipodermatosclerosis, and you can appreciate, hopefully from low power, that you have a lot of fat necrosis here and fibrosis of the septum, but not a lot of primary inflammation. It doesn't look like there's active granulomas or anything that we would expect in erythema nodosum. And so going in close, you could see this sclerosis even extends into between the lobules of fat, and it involves here the dermis, where there's a little fibrosis and a little sclerosis, and we're going to talk a little bit in the next section about what the difference is between those terms. And then if you go in even closer, you can see in the fat, as it's dying, it's getting these wavy little bits. It's been referred to as the arabesque sign because it reminded somebody of a ballerina with their leg sticking out in the back like an arabesque position. But regardless, whatever you see it as, it's this ribbony change in the fat cell wall that happens as it's dying. And that's pretty characteristic of lipodermatosclerosis. So here's the fibrosis and the sclerotic changes that happen. Here's another case and a close-up look at the lipomembranous change. Okay, and then we move to subcutaneous fat necrosis of the newborn. This is a lobular panniculitis. Again, mixed inflammation. That's sort of the hallmark and difficulty with panniculitis, that there's so much overlap in the inflammation. But this particular one has mixed inflammation with fat necrosis, where the fat cells retain their shape and they're filled with these pink strands and needle-like clefts, which are actually triglycerides. So here, actually, if you see a lot of skin, you can tell that this is baby skin. Your little adnexa are small, your fat is very high. Size-wise, this tells me that I'm looking at a little baby skin. There's also no sun damage, but here we can see the inflammation is all localized to the fat. And you don't only have that cleanup job with the histiocytes, you have primary inflammation with the lymphs and the newts and the eos. And then here you see the fat cells accumulating this pink material and these clefts indicating the triglycerides. And the fat varies in sizes because it is being traumatized in this inflammatory process. Okay, so this is fairly pathognomonic for subcutaneous fat necrosis of the newborn. In the vasculitis section, we talked a little bit about polyarteritis nodosa, but we'll allude to it again because it's good to have overlap and repetition. So again, you can have polyarteritis nodosa, which occurs in the arterioles at the bifurcation in the subcutaneous tissue. And the differential for that will be something like a nodular vasculitis. So the difference is that polyarteritis nodosa localizes the inflammation around the artery, and it spills over a little bit into the fat. Whereas erythema induratum or nodular vasculitis, you will have a prominent lobular panniculitis that also involves the vessel. Superficial thrombophlebitis might be a similar looking picture. So again, here is a picture of our polyarteritis nodosa, our muscular walled vessel here in the fat with inflammation. This is a blurry picture, but you can see that the inflammation spills into the fat, but is not predominantly a lobular panniculitis. Here's another case, and here you see in the fat at the bifurcation of the artery, you have inflammation. Closer up, that inflammation spills into the fat, but is not primarily, as you can see from these other sections, a lobular panniculitis. Here's up close, you can see that layer of fibrin that we talked about, the gummy pink indicating damage to the vessel wall. And you see all the inflammatory cells, mixed infiltrate, newts, eos, lymphs, everything there kind of damaging the vessel. Here's another picture. Here you have the fibrin and the mixed inflammation of your artery. Here is a side-by-side, because I love side-by-sides, of PAN with the inflammation focusing around the vessel, because it's primarily a vasculitis with resultant panniculitis, and erythema nodosum / nodular vasculitis, where you have prominent vasculitis, but also equally prominent lobular panniculitis with granulomatous features often. Okay? Moving on, we're going to talk about alterations in collagen and elastin. So first, if you look at Merriam-Webster's definition of sclerosis and fibrosis, you'll see these definitions. Sclerosis says any pathologic hardening or thickening of tissue, and fibrosis says the formation of excess fibrous tissue as in a reparative or reactive process. So often people use these terms interchangeably because clinically it's sort of hard to distinguish them. When we talk about fibrosis and sclerosis histopathologically, we are talking about different things. So sclerosis I define as increased collagen with a decreased ratio of fibroblasts relative to normal. So this is going to look homogeneous and pink. And fibrosis, in contrast, is increased collagen with an increased ratio of fibroblasts. So it's going to look more cellular than normal skin, but also with increased collagen. So what are we talking about here? This on the bottom is a picture of normal skin. This is the normal configuration, wavy configuration of your reticular dermis. And this is about the normal concentration of fibroblasts in your skin. This, in contrast, is sclerosis. You can see you have more collagen packed in there. But if you took a section here and looked at it, you would have a lower ratio of fibroblasts than you do here. That is sclerosis. Here is fibrosis. This is a scar forming. If you took a section here, you could see that the collagen is more dense. It's oriented horizontally because collagen's firm. You pack it in, it's going to kind of orient. So it's oriented horizontally, and you have a significantly increased number of fibroblasts in there. That's fibrosis. It's important because if you take a look at something with altered collagen and you divide it into the sclerosis category or the fibrosis category, the differentials are completely different, and it'll help you go down the correct direction in your ladder of differentials. So first we're going to talk about sclerotic conditions. So again, increased collagen, decreased ratio of fibroblasts. So like in sclerosis, the characteristic features are going to be hyperkeratosis. That means your cornified layer is thickened. You have a thin epidermis. You may have a little bit of evidence of an interface change at the DEJ because it starts as lichenoid inflammation that moves downward in the dermis and leaves behind the sclerosis. And then you're going to have this broad zone of homogenized collagen, which is the sclerosis. You may or may not have edema as well. So this is an early lesion of lichen sclerosis, and you can see very clearly where your lichenoid band is. This is in the vulvar area, and you can see a little bit of vacuolar alteration, and if you look closely you might see a necrotic keratinocyte or two. That's your interface, and your lichenoid inflammation has moved down just a touch, and here you can see in this zone, this is not the look of normal papillary dermis. It's homogenized. There's increased collagen filling it in, and there's a relative decreased number of fibroblasts, and that's why it looks so homogeneously pink. So early lichen sclerosis. Looking up close, here's your necrotic keratinocyte, here's a lymphocyte causing your interface, here's the rest of your lichenoid band that's moving down with your melanophages, and here's this pink sclerotic zone that's being left behind. Here is a very well-developed lesion of lichen sclerosis, and what you can see is that your lichenoid band has moved all the way down to here. So it started up here and it moved downward, and as it moved downward, it left behind this homogeneous zone. Sometimes it's difficult to distinguish lichen sclerosis from morphea because morphea can involve tissue all the way up to the surface. But this band, this evidence of the lichenoid band that moved downward, helps me often distinguish between true lichen sclerosis and morphea with a superficial component. Here you have this homogeneous pink color, because if you look up close, you have increased collagen and relative decreased numbers of fibroblasts, homogenized collagen, okay? Thin epidermis, compact orthokeratosis, probably a little bit of evidence of remnants of your lichenoid inflammation there. Here's also spaces that are the edema that can happen with lichen sclerosis. Here's your hyperkeratosis, your thin epidermis, you know, damage at your DEJ from your old lichenoid inflammation. So Morphea scleroderma is also sclerosis. You're going to have anything that's fibrotic or sclerotic. The collagen is space occupying. So what it's going to do is it's going to squeeze out your hair follicles. You're not going to see them anymore. It's going to squeeze out the fat that's around your eccrine coils. Early lesions, you're going to have a perivascular and interstitial infiltrate of lymphocytes, and then with time you'll have plasma cells. Earlier in the last chapter we talked about a lymphocytic infiltrate, and what we were talking about was either perivascular, superficial and deep, or perivascular and periadnexal, right, with the collagen vascular. Morphea has an interesting pattern because it's perivascular and interstitial infiltrate of lymphocytes, which you don't see in that many conditions. And then when you're dealing with systemic sclerosis, it tends to have less inflammation. So here's a biopsy. Some would argue it's square, but as I talked about in the normal skin chapter, anything from your back might be square because you have a lot of collagen, but you have a lot less space between your collagen bundles than you normally would. And if you look in the inflammation here, you have perivascular, but also a little bit of busyness in the dermis from your inflammation. You're missing your hair follicles. There's not a hair follicle in sight here. And then looking up close, you can see that you have this homogenized collagen that's thickened. And these cells that are in between the collagen bundles, they're actually not fibroblasts, they're lymphocytes. That's your perivascular and interstitial lymphocytic infiltrate. In the background of sclerosis, that's going to tell you this is probably early morphea. Maybe an interstitial drug would be on your differential. Maybe an interstitial manifestation of mycosis fungoides might be on your differential, but there's not that many things on that differential, okay? Perivascular and interstitial with lymphocytes. Think morphea. Here's a picture up close of your sclerotic collagen and your perivascular lymphocytic infiltrate. And then with time, eventually your infiltrate goes all the way away. You might see a plasma cell in there. Early on, you might see eosinophils. Morphea is quite itchy in the beginning, and it correlates with that. Here's a picture of your lymphocytes diving between your collagen bundles, okay? They're kind of smashed in there in their interstitial pattern. All right, so that's morphea. Now we're moving on to chronic radiation dermatitis. So radiation dermatitis starts as a dermatitis, and then it becomes more fibrotic with time, and then when it's very chronic, it becomes sclerotic. You will see hyperkeratosis. You may see an atrophic or even ulcerated epidermis. You'll see sclerosis, and the difference between morphea and LSNA and chronic radiation dermatitis is that you're going to have funny looking fibroblasts. Sometimes they're stellate, sometimes they're not. They're just big and funny looking. We call these radiation fibroblasts. You'll have irregularly dilated vessels. So you might have a little bit of telangiectasies in the other conditions, but they won't be kind of very largely telangiectatic vessels. And again, no hair follicles. So here's a picture of chronic radiation dermatitis. Look how big these vessels are. Okay, so that's not something you're going to see in morphea or LSNA. When you look in close, see this section almost devoid of fibroblasts? That's your sclerosis. But when you do have your fibroblasts, I hope you can all appreciate that they're quite large and they're different than normal fibroblasts. And here's your big dilated vessel again. Here's an example of an ulcerated lesion of chronic radiation dermatitis. When you have your ulcer, you'll have granulation tissue, and early on you'll have fibrosis, which you have here, where it's more cellular. But with time, you will go on to progress to sclerosis. And here again, look at these big fibroblasts. So big fibroblasts, big dilated vessels in sclerosis. Think about chronic radiation dermatitis. And here you're going to see plasma cells, because anything going on for a long time, you'll have plasma cells. You might see some eosinophils. You can see anything in the inflammatory areas, especially if they're traumatized. And lastly, on the sclerotic differential, so there's not that many: lichen sclerosis, morphea, chronic radiation, and now Sclerodermoid GVHD, which hopefully you would get some clinical information for. You would have the sclerosis of the dermis that could be hard to distinguish from any other sclerosis, but you're going to have a very subtle vacuolar interface. So when we talked in our interface chapter about the range of lichenoid with many lymphocytes to vacuolar with very few, you will see how subtle the vacuolar interface can be in GVHD. So here we have a lot of hyperkeratosis and epidermal acanthosis, and then you will note here we have sclerosis of the dermis. And then when we go in close, you're going to see here that your DEJ is a little jumbled. Your cells are not orderly the way the basement membrane should be, and that's because they're unhappy and damaged. You see a few keratinocytes starting to die early, a little bit of your vacuolar change. When they say satellite cell necrosis, what they really mean is that one single lymphocyte kills one single keratinocyte, and that might be all you see to indicate the damage. Here is the dermis. Again, large, thick collagen bundles, relative decrease in fibroblasts, sclerosis, okay? Here's another case. Here you can appreciate the sclerosis. It's sort of choked off the fat, and the adnexal structures is pushing them away. You have a little bit of pigment dropout, probably from, a very subtle interface that happened. I think even in this section, I couldn't really see good interface, but here you have the sclerosis. So GVH is sort of the hallmark of very paucicellular interface, and then you either have, just the lichenoid version of GVH, or you have the sclerodermoid type of GVH. Here you can just appreciate the DEJ, how subtle. I can't even see really any interface. You might have to level a few times to see really one good necrotic cell with one lymphocyte. They're damaging it. But the pigment dropout does sort of suggest to you that it's happening. Oh, sorry, one more sclerotic condition, eosinophilic fasciitis, which many of us just lump into the category of morphea profunda, or like just really deep morphea. And here you'll see sclerosis of the subcutaneous septa and the fascia beneath your subcutaneous tissue. And you may or may not have a lot of eosinophils. That's more of a clinical, like in your bloodstream, you might see eosinophils. But here's your fat. If you can imagine your biopsy, above it is where your dermis and your epidermis are. So this is below your subcutaneous tissue. You can see this thickening. When you look up close, you see thickening. Yes, there's some cells, and yes, there's some fibroblast increase, but mostly it's this homogenized pink, suggesting the sclerosis that's happening beneath the fat. And that's what you see in eosinophilic fasciitis, and that's what you see in Morphea profunda. Okay, switching gears now, we're going to talk about fibrosis. So increased collagen with relative increase in fibroblasts. The hallmark of this is going to be a scar, or if you have ropey collagen, it's going to be a keloid, stria. Scleromyxedema and nephrogenic systemic fibrosis, I put in this chapter. You can put it in different chapters. You can put it in mucin deposition. You can put it in fibrosis. I like to put it here because you do notice a lot of fibrosis. And then if you see a lot of fibrosis with mucin deposition, then you think of these entities. Okay, so this is early scar formation. You see the collagen, rather than being ropey and twisty, it's kind of oriented. And these are all fibroblasts, and they're laying fresh collagen, and it's more blue when it lays fresh collagen. And you can see it's a relative increased number. Immature collagen is blue. You see, you bring a lot of your extracellular matrix that's going to show up as mucin when you build collagen, and when it thickens, it's more red because that goes away. So just to review scar formation, well, what happens when you build a scar? You start with granulation tissue. You have angiogenesis. You got to bring blood vessels in to feed your new scar. You migrate your fibroblasts and you proliferate them. You build your extracellular matrix, and then you remodel your collagen, and you have a whole bunch of inflammation in there while you're doing it. Just as a review, when you damage an endothelial cell, so anything that draws blood, you're going to release tissue factor, and you're going to enter the extrinsic and intrinsic pathway, which I have very little recollection of, but that makes prothrombin become thrombin, and then fibrinogen becomes fibrin, and with factor 13A, you're going to make a clot, okay? So here you can see that there's an ulcer. There's an ulcer, and all of this pink gummy material is your fibrin. That's your clot. So it went through the cascade and made a clot to stop the bleeding. And now you're forming your granulation tissue. Here's your blood vessels. Your extracellular matrix shows up as edema and mucin. You have inflammatory cells, and you're going to bring fibroblasts to start laying collagen down. Here's an example of granulation tissue. Again, blood vessels, fibroblasts, inflammatory cells. This is a new scar forming. It's still very blue. Your blood vessels are here. Your fibroblasts are forming. Here it's very blue and it's new, and this is mature collagen, which is red on the bottom, okay? I can virtually tell the age of a scar by what it looks like. Now you're a little bit less blue, and you're more mature. Your inflammation is going down, and you've got this horizontal collagen. You see it squishes your vessels and makes them orient vertically. And then eventually it'll all be red. See, here's your vertical vessels. Your collagen is kind of oriented horizontally because it's firm, right? So what's a keloid? Well, if you take that horizontal collagen and you wrap it into a ball that looks like different fascicles, you have a hypertrophic scar. If within that hypertrophic scar, you develop these large eosinophilic ropey collagen bundles, that's when you've become keloid. So if you look off on the side, this is that same scar that we saw earlier. It was just that horizontal area wrapped up into a ball. But if within that scar, you start to get these big, thick, pink, ropey collagen bundles, that's when you tip over from hypertrophic scar into keloid. Here's an up close on the ropey collagen bundles. Here again, this is all hypertrophic scar. So you can see that you have horizontal areas, squished little vertical vessels, and you've wrapped it so they're going all in different directions when you cut it and look at it two-dimensionally. And then here in this section, you can see these pink ropey collagen bundles. If I only got this, I would call it hypertrophic scar. As soon as you see this, you call it keloid, okay? And again, fibrosis, right? Increased fibroblasts. With years and years and years and years of time, you can eventually become very sclerotic in your scar, but initially it's fibrotic. So nephrogenic systemic fibrosis I put in this chapter. The fibrosis is haphazard, and you'll notice increased mucin. This was an entity that was pretty prevalent when I was a resident, and they were, you know, people with end-stage renal disease were having gadolinium deposits from the contrast with their MRIs, and after that was identified, hopefully the disease is now waning and you hardly will see a case. But we were seeing this a lot for a while, and it looks exactly like scleromyxedema to some degree. So this is a case, and you can see it's a very busy dermis. And when you look up close, all of these cells are fibroblasts, okay? It's a significant increase in fibroblasts, which is why I put it in the fibrosis chapter. But there's also a significant deposition of mucin, so some people put it in the depositional chapter. There's different ways to skin a cat. You might see a few giant cells, but fibrosis, increased mucin, you think about NSF and you think about scleromyxedema. Now, if the biopsy goes through and through like this, and certainly the clinical presentation is different of, you know, woody hardening that starts distally and moves proximally, then it's more likely nephrogenic systemic fibrosis. Here's another example, it's very cellular, and all this space is where the mucin is packed in. Okay, scleromyxedema, on the other hand, you may have that woody hardening, but a lot of times it's very papular. So you might see that involvement only in a section of the biopsy as opposed to through and through the whole biopsy. Again, you have fibrosis and then increased mucin. So here's an example. And if you look up close, you have increased fibroblasts, a little bit of fibrosis, increased mucin. Not quite as cellular and busy as that NSF case, but that's not always necessarily true. All right, other alterations in collagen. You know, we inject a lot of Kenalog, we use a lot of topical steroids. Sometimes you have atrophy of the dermis. And so what you can appreciate is this contracted appearance of your vessels. Normally we have, you know, our round vessels that are our superficial plexus, and I hope people can appreciate here, it's almost like a deflated balloon. They deflated the collagen, and now they've kind of squished together in this vertical orientation. It's pretty subtle, so, you know, it takes sort of years of experience to be able to pick it up, but you have sort of increased space between your collagen bundles and this deflated look reflected in the way your blood vessels appear. And that's dermal atrophy. If you have epidermal atrophy, then you'll have thinning of the epidermis too. So that depends on if you're putting the steroid on from the outside or you're injecting it underneath on the inside. Okay. Chondrodermatitis nodularis helicus is in this chapter because you have the erosion with the fibrin, right? The fibrin tells a story that there's been tissue damage. Sometimes I'll get excisions and someone will have curetted, say, a basal cell right before the excision, and I will know that that ulcer I see is from a curetting and not from a true ulcer because there wasn't enough time to build fibrin there, okay? So erosion with fibrin. Looks like prurigo because it is essentially prurigo, right? Chronic pressure creates this eroded prurigo-like lesion, and then the fibrin is there to plug the damage, and then you'll have fibrosis or sclerosis of the underlying collagen because of the, you know, the reparative process. If you get a piece of cartilage, that's a clue. So here you have this thickening, right? A little bit of a thickened epidermis, hyperkeratosis, that's sort of like your prurigo type change. And even though you don't see the erosion in this particular section, if you leveled it, you would see it eventually because you have fibrin here. This fibrin tells you that there was damage and somewhere there's an erosion or an ulceration that got down to the vessel and damaged it. And now you have this deposition here. And then below that, you have granulation tissue. You're going to start to repair anything that was damaged. And you see it displaces the solar elastosis you see in this sun-damaged piece of ear skin. Here's another example. You have an erosion. Here you see the erosion in this section. Here's your layer of fibrin, that gummy pink stuff. Here's all your granulation tissue, and here's your little bit of cartilage to show you that you're in the ear. Without the cartilage, this is kind of what any area of chronically picked or traumatized skin will look like. Okay, perforating collagenosis. This is in this chapter because there's collagen perforating. And here we have a cup-shaped depression of hyperplastic epidermis. So it creates a channel, almost looks like a hair follicle, but it's not really a hair follicle. Sometimes it involves a hair follicle, and it raises the question, is there a separate condition that's perforating folliculitis? So if you have a lot of follicles and it's between the follicles, it's not related, it involves the follicles, it could be that, or they could be all the same thing and just a perforating collagenosis that may or may not involve the follicles. Regardless, it's filled with debris, parakeratosis, inflammatory cells, and then you'll see vertical strips of collagen. So here you have this thickened epidermis kind of making this channel, right? And it may or may not be a hair follicle, and a 4-millimeter punch, you may not be able to tell. And it's filled with this debris. And this debris, you can see, has a few inflammatory cells, dead cells, and then you see these ropey collagen bundles rising up through. If you wanted to use a trichrome stain, you can. In this particular instance, your trichrome stain stains your dermis and your epidermis red. Sorry, your epidermis red. Your collagen here is blue, and your nuclei are black. And you can see these blue collagen bundles perforating up through the channel. Okay, now switching gears, we're going to talk about elastic tissue. You can perforate collagen, you can also perforate elastic tissue. So elastic tissue tends to be smaller. I don't know if that really has to do with it, but the channels I've seen for elastosis perforans staphylosis tend to be smaller than the channels for perforating collagenosis. Again, you have this channels filled with all this debris, and you'll have these elastic fibers, which are thinner than collagen fibers. So here's your little channel, like we saw before, epidermal hyperplasia, making this little space. And then what we should see is thin little elastic fibers. You see these little thin elastic fibers moving up through the channel. And if you can't see them, you can stain them with an elastic stain. Here you go. EVG, VVG, whichever elastic stain you use would highlight those. Okay. Favre-Racouchot is in this chapter because of the nodular elastosis. So solar elastosis is the sun damage, and then with really bad sun damage, you can get cysts and comedones, and so that's exactly what you see. Here is an example. You see that gray dermal material, that's your solar elastosis, and then you have all these little cysts, milial cysts forming, and that's what you see in Favre-Racouchot. Which in contrast, in our neoplastic section later, we'll see a trichoadenoma may have many cysts, but then you'll have a stroma, a fibrotic stroma around them, which will push away the solar elastosis. Here you just have individual cysts in this sun-damaged background. Ochronosis is in this chapter because the homogentistic acid of primary disease or hydroquinone derivatives bind irreversibly to the collagen bundles, giving it the yellowish color. So these bananas are not fully foreign material. It's actually the foreign material bound to the collagen fibers that gives you the full banana, okay? Ochronosis. And then we have pseudoxanthoma elasticum. So normally outside of EPS or any other condition like pseudoxanthoma elasticum, we can't usually see elastic fibers on H&E. The only reason we can see them in pseudoxanthoma elasticum is because they're calcified. Okay, so calcium lines, and as we know, calcium has this kind of pink purple color, and then we're able to see them. This is an inherited ABCC6 mutation disease, or it can be drug induced with penicillamine. The histopathologic findings are identical. This slide is faded, but what you can see is down in the dermis, you have these little fragmented curly fibers, and what these are elastic fibers that are calcified. Normally, see in the normal collagen, you cannot appreciate your elastic fibers without a stain. So, pseudoxanthoma elasticum. And that's it for your chapter. We're making progress, so I will hopefully be releasing the next one in a matter of a few days.